Thank you, everyone. And so the next session will be presented by Dr. Stephen Johnson. Dr. Johnson is a professor emeritus of medicine in the Division of Infectious Disease at the University of Colorado School of Medicine in Aurora. He has focused his career on HIV care and the care of other infectious diseases and the education of providers on infectious diseases. He serves as the director of the University of Colorado Ryan White HIV Clinical Program and the medical director of the Colorado AIDS Education Training Center, and is co-investigator on the NIH-funded Colorado Infectious Disease Clinical Trials Unit. He is member of the HHS panel on antiretroviral guidelines for adults and adolescents living with HIV from 2018 to 2025, and the IDSA COVID-19 treatment guidelines. And he'll be talking to us about a focused approach or focused update immunization practices for people living with HIV. Thank you, Dr. Johnson.
Thank you, everybody, for sticking with it this afternoon. Thanks to the co-chairs and the organizers for inviting me to talk about this subject. Excuse me, just recovering from being with my grandchildren. So no financial disclosures, and we're going to talk today. I've called it a focused update on immunizations just because it's a broad topic and we can only cover so much in 30 minutes. But I do think it's important for us, especially with the federal climate and all of the misinformation out there, for us to really be advocates for vaccines and vaccine providers for people living with HIV. And so it's important for us to be up to date on this topic. We're going to talk about specifically several diseases and vaccination for those diseases. We'll talk about COVID-19 vaccine, talk about Mpox vaccination. We'll touch on the hepatitis B issue, including vaccination. We've covered some of that already in the panel that we just had, and then talk about the measles outbreak, and then end by just making some points about vaccine hesitancy. So this is my kind of version of the HIV adult immunization schedule as it exists now. It is it really is obviously trying to mimic the adult immunization schedule from the CDC, but it has some specific points about HIV. And there's about 13 different vaccines that are listed here. So it's really quite a project, I think, to keep your patients up to date with immunizations. It's helpful now with the electronic health record, especially if you have a health maintenance module that helps you to track vaccines and so on. But there's enough vaccines that this really is a topic for almost every visit when you see the patient. So let's start with the COVID-19. There are currently 4 COVID-19 vaccines that are available. There are 3 mRNA vaccines. Moderna has a new mRNA vaccine called mNEXSpike. And by the way, I tend to use kind of brand name for vaccines because I think it's important for recognition, both for providers and patients. But the mNEXSpike vaccine is encodes for a narrower portion of the spike protein, and so it is given at a smaller dose. In a comparison with the other Moderna vaccine that encodes for the whole spike protein, it was found to be non-inferior, but it has been FDA approved for individuals over 65, and then for younger individuals that have a risk factor that places them at risk for more severe COVID-19. And so these are the 4 vaccines that are available. Guidelines generally do not specify which of these vaccines to receive. If you followed the literature early on in the COVID-19 pandemic, there were some studies, case series, retrospective studies that might have suggested that the Moderna vaccine had somewhat higher, better outcomes than the Pfizer vaccine. But I think where we are now in the pandemic, where people have received multiple doses of vaccine, many people have had multiple infections with COVID-19, I think kind of choosing between these vaccines is really more kind of what your health system chooses or what's available for the patient. One point I want to make is that our population of people with HIV, actually many of them have the traditional risk factors that we associate with worse outcome with COVID-19. We brag, of course, about how old our HIV patients are now, that they're no longer dying from HIV-related complications. Obesity is more common in HIV. We just talked about weight gain with ART, cardiovascular disease, lung disease as a group, higher rates of tobacco use in people with HIV. Diabetes mellitus is a common comorbidity. We have increased non-AIDS cancers in HIV, and then gender in the studies of COVID-19. Men were more likely to die than women. And of course, at least in where I practice, about 80% of the pandemic is men. And then, of course, patients may also be immunocompromised from HIV itself if they're not on therapy. And in fact, COVID acts like an opportunistic infection of sorts in people with HIV, at least earlier in the pandemic. This was a study looking at a composite outcome of ICU admission, mechanical ventilation, or death, and looking at individuals with HIV based on their baseline CD4 count. As you can see there, if your baseline CD4 count was less than 200, you had 3 times the risk of that composite outcome compared to individuals whose CD4 count was greater than 500. In fact, I lobbied that COVID be a chapter in the OI guidelines, but I think it's actually mentioned in the pediatric OI guidelines. So the question is whether vaccination is still necessary in the current era. The National Center for Health Statistics just released their information. Last year in 2024, COVID-19 was either the cause or a factor in 47,000 deaths in the United States. That meant it dropped out of the top 10 for the first time since 2020. And so far this year has been associated with 15,000 deaths. So it's still with us, although not quite the magnitude that we experienced earlier in 2020, 2021. But I've included a couple studies here that look at the last formulation of the COVID-19 vaccine that we have data for, the 2024-2025 vaccine. And this is a study that looked at outcomes in US veterans, and it looked at a group who received both the COVID-19 and flu vaccines on the same day and compared to a group that only received flu vaccine. And as you can see in the graphs on the right, but also in the text, that vaccine effectiveness against a composite outcome of emergency department visits, hospitalizations, and deaths was 29%. So not quite as impressive as some of the early data that we had with vaccines, but still showing a benefit. Similarly, this is another study from the MMWR that from 2 large networks, Vision and IV networks, that looked at the vaccine effectiveness of the latest formula. And it was 33% against COVID-19 associated ED visits among ages greater than 18 years, and 45 to 46% against hospitalizations. And actually, they also looked at a subset of immunocompromised adults aged greater than or equal to 65, including some people with HIV, and the vaccine efficacy was 40%. So when patients come into your clinic now and say, well, is this latest vaccine, effective? Is it helpful? I think the answer is that it still is helpful. We obviously don't have data for the latest iteration, which is the 2025-2026 vaccine. So I think all adults and adolescents with HIV should get the COVID-19 vaccine regardless of their CD4 count or HIV viral load. The mRNA vaccines are the primary immunizations that are in use. Those with severe immunosuppression may have a diminished immune response and are candidates for additional doses. And I've done this in some of our patients that have had CD4 counts less than 200, for example. And then people with HIV who are 65 years and older should consider a booster dose 6 months after the initial dose. So that's where we are with COVID-19. And if you have additional questions, we can handle that in the question and answer section. So let's turn to Mpox. As you know, In 2022, we had a major outbreak of clade 2 Mpox cases in the United States, and this is the epidemic curve. And if you look at the y-axis for the table on the left for 2022, you can see we're measuring in the hundreds of cases per day. And on the right now is the latest information for clade 2 Mpox cases in the United States in 2025. You may see kind of a little bit of an increase here recently, but again, looking at the y-axis, 5, 10, and 15. So we're seeing Mpox. We continue to see it, not at the rate that we initially saw that, and presumably, potentially, the lower incidence is related to vaccination and or prior infection, which can produce significant immunity to reinfection. Now, when this was initially described in 2022, the severe cases were predominantly involving immunocompromised patients, especially people living with HIV with CD4 counts less than 200, and especially individuals who are not on antiretroviral therapy. So this is one of the studies that was presented from the CDC when they consulted on 103 persons who were hospitalized with severe manifestations of Mpox. And you can see most of them were people with HIV. Most of the people with HIV had a CD4 count less than 200, and all the people who died had HIV, and there were no deaths among people with HIV who were taking antiretroviral therapy. So this is another viral infection that is opportunistic for people with advanced HIV. So recommendations for the Mpox vaccine. It's obviously a subset of the people that we take care of, people who are not sexually active, people who are in a monogamous relationship, probably are at little or no risk for Mpox. So there are a set of kind of criteria to think about and so on. I tend to think about the Mpox vaccine in the same group of people that I think about doxy post-exposure prophylaxis. So people who are sexually active, multiple partners, and are at higher risk. So the available vaccine is a live, non-replicating vaccine, and it's the preferred vaccine before Mpox exposure, and it's safe in people with HIV, including people with a CD4 count less than 200. The regimen is 2 doses, 28 days apart. It can be given post-exposure, ideally 4 to 14 days after exposure, and it should be given to those that we determine have risk, and also those who request the vaccine. There's a question that comes up relatively frequently in clinical practice, and that's about boosters. At this point, there are not recommendations about boosters, except the ACIP guidelines have some specific recommendations for boosters among laboratory people that work with these viruses. We don't have a lot of experience, but we do think the vaccine is expected to also protect against clade 1 strains, and that's relevant because there have been a few imported cases of clade 1 Mpox and several cases reported in California. I want to talk about hepatitis B, and we've already kind of talked about this a little bit, but since one of your test questions is related to this, we better go over it again. But one of the points that I want to make is that we have kind of an evolution of antiretroviral therapy that is actually, we have a lower percentage of people who are now on tenofovir containing regimens. And we've kind of relied on tenofovir containing antiretroviral therapy to treat chronic hepatitis B. And then, of course, as I mentioned, it may also act as a bit of a PrEP agent against hepatitis B in people who are non-immune. But we're using more 2-drug oral regimens, including injectable cabotegravir rilpivirine. So I think it's important for us to be cognizant about hepatitis B status and make sure that our non-immune individuals are vaccinated. And towards that end, we have I guess it's not a new vaccine at this point, but the vaccine conjugated to CpG or Heplisav is a much more potent vaccine. One of my jobs at University of Colorado is part of the vaccine committee for our UC health system, and we've actually used this as our primary vaccine for all individuals um, who get the hepatitis B vaccine, not just people who have HIV. So this is really the preferred vaccine schedule for people with HIV, given 2 doses, 0 and 1 month. Now, we alluded to a study of this newer vaccine, ACTG 5379, which looked at the immunogenicity and safety of this vaccine in people living with HIV, and also looked at a 2-dose regimen and a 3-dose regimen. And a 2-dose regimen was actually highly effective with high rates of seroprotection, but a 3rd dose led to even higher rates of seroprotection and higher titers of hepatitis B surface antibody. So the guidelines, even though the kind of standard approach is 2 doses, in the guidelines, there is the option to consider a 3rd dose that might provide seroconversion in somebody that does not seroconvert with 2 doses. Now, we talked about this, so I'll just mention this just because, again, it's something that I think is a little bit confusing, and as we talked about in the panel, maybe a little bit controversial. There is a differential diagnosis of isolated hepatitis B core antibody positivity. As mentioned on the panel, the most likely cause is remote infection, where you've lost surface antibody. We used to kind of more routinely check hepatitis B DNA, because one of the thoughts for core positivity was low level active hepatitis B, but not high enough to trigger the surface antigen. But that turns out to be an uncommon scenario. So routinely checking hepatitis B DNA is not recommended. As mentioned, a false positive is also in the differential diagnosis. So the approach to the isolated core antibody is to give a single dose of vaccine and then a month later remeasure titers. And if the titers are very high, greater than 100, then no further vaccination is needed. But if the titer is less than 100, a complete series of hepatitis B vaccines should be completed and then followed by anti-HBs testing. All right. Well, measles, of course, is somewhat of a hot topic now because we've had a series of outbreaks in the United States, series of outbreaks in Canada, and this has been maybe countered by a sluggish federal response to what's going on. This is the map of measles cases in 2025 as of November 12th here. And you can see most states have cases. And in fact, there now have been 1,700 confirmed cases, probably additional probable cases from 42 states. Most of these are in people 19 and under, and the vast majority are in individuals who are either unvaccinated or of unknown vaccination status. A significant proportion have been hospitalized, but only 3 confirmed deaths, so that's good. So there's 2 available MMR vaccines in adults. It's a 2-dose series, at least 28 days apart. In the general population, the vaccine is 97% effective. And measles cases in vaccinated persons tend to be milder. And MMR is one of the vaccines that's contraindicated in HIV positive persons with a CD4 count less than 200. So important to keep that in mind. So the presumptive evidence of immunity can be established in any of the following ways: written documentation of vaccines, laboratory evidence of immunity, laboratory confirmation of disease, and birth before 1957. But in terms of that last criteria, I followed a number of individuals born before 1957. And of course, everyone's asking about their measles status and so on. And I found a significant number of people with negative titers with birth before 1957. So, especially if, measles is active in your area and so on, I think it's reasonable to screen for immunity and immunize those that are not immune. And, in the process of screening with measles, mumps, and rubella, we've also found a number of negative results for the other two viruses as well. So I think this, especially with the outbreak of measles and unclear trajectory and so on, I think this is an important part of practice to talk to your patient about it and perhaps screen. All right. I want to talk a bit about vaccine hesitancy. And on this slide and the next slide, I've listed some of the components of vaccine hesitancy. And I guess one of the major points is that vaccine hesitancy is not just one thing. It's many different things. And as you look at this list, you can probably think of maybe individual patients you take care of and so on in terms of how they've responded to in terms of not getting vaccines and so on. We have a lot of negative information now from media, from the federal government, a lot of, I think, I wouldn't even call them mixed messages. I would call them, messages that are not accurate. They're not evidence-based. Vaccine safety, there's been a lot of kind of focus on that with the secretary's concern about autism. Lack of information, I think, is an important issue. Health literacy is an important problem. So I think that's something that can be addressed. Too many vaccines, especially if you're seeing somebody newly diagnosed with HIV, it's pretty easy to overwhelm them with, well, you need this, 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 and this. How many would you like this time? Do you want to get 3 today or 4 today or so on? So I think that's an issue. Approved too fast. There was a subset of people that wouldn't get the COVID vaccine when it was under an emergency use authorization that then once it was FDA approved, agreed to get it. Diseases are beneficial. That's out there as well. I'm old enough to remember taking kids to chickenpox parties, because you kind of expose them to chickenpox so they get immune at a young age. And so on. That was kind of a thing there at that time. Fear of injection, lack of access, lack of recommendations from providers. I think, if you're not making a discussion of vaccines part of your standard of care visit, then I think people view that as maybe not important. And then the last point, the need for shared decision-making. I found this to be kind of an interesting thing because in general, we think shared decision-making is a great thing. But if you're trying to really promulgate vaccine use and you're trying to universally give vaccines and so on, if you actually tie it to a physician or that they have to go see somebody, then there's a subset of people that either don't have a doctor or maybe don't have a doctor who's knowledgeable about vaccines. There's been a lot of vaccine hesitancy about surrounding COVID-19, and I just find it baffling. I'm an older physician, and I can think of only 2 things that I can think of that saved millions of lives: antiretroviral therapy for treatment and prevention, and COVID-19 vaccines. It's just remarkable kind of how this changed the epidemic. And I've chosen a study which is probably the study that shows the most mortality benefit, but there are many other studies that show a significant savings of really millions of lives with these vaccines. And it's just kind of surprising that that we run into such difficulty. So how do you approach vaccine hesitancy? I think it's important as providers to provide strong recommendations, not to kind of say, well, you could probably get a dose of this, or, if we send messages like that, I think that promotes vaccine hesitancy. I think asking open-ended questions and to try to, of all the list of things I listed, try to figure out, what makes that your particular patient hesitant? Is it an education issue? Is it a fear of needles? Is it and kind of sort it out, and then provide the intervention to help get them to get vaccinated at this visit or at subsequent visits. So personalized education, review the scientific evidence, explain the collective benefit of vaccines. I think one of the issues with the COVID-19 vaccine is most consumers of healthcare consume healthcare for their own health. And this idea that you would get a vaccine so that you wouldn't spread it to your grandmother and so on was a bit different, concept. And then I think discussing at multiple visits, I can think of countless examples where you bring it up at a visit and people are, where they're going to think about it and so on. And then when you see them on the next visit, now you bring it up again, and it sends a message to them, oh, he must really think this is important, and I've had time to think about it and so on. And I think studies have shown, despite the effect of the internet and Facebook and the federal government and so on, patients tend to trust their provider over anyone else. And so if you're there kind of as a strong advocate and so on, I think you can overcome at least some of the cases of vaccine hesitancy. So vaccines play an important role in HIV primary care, and I encourage you to kind of have a chart like I've created to kind of keep track of the vaccines. You can argue that both the hepatitis B vaccine and the HPV vaccine actually prevent not only infection, but cancers. Despite the declines in morbidity and mortality, I think regular COVID-19 vaccination is an important part of HIV care. Obviously, Mpox vaccination should be considered in people at risk. Despite the lower number of cases, Mpox is an STD, and what we know from STDs is that they can rapidly change and become much more common, as we saw initially in 2022. Just a reminder about hepatitis B status and the importance of vaccine, and then we talked about measles. So one of the questions is with the situation with the CDC and the ACIP, where do you get good immunization advice? Well, the DHHS OI guidelines is one source. There's a whole chapter on immunizations, and so I'd encourage you to look at that. The IDSA just released guidelines for immunocompromised patients. There are state and local guidelines. There's the National HIV Curriculum. There's a variety of other sources. I think the days of kind of relying on the CDC and the ACIP is kind of this, steady source of very accurate information. I think that's under threat now. So I think we have to kind of look at alternative sources. And with that, I'll stop, and I'll be happy to answer any questions that you have. Thank you.
Thank you, Dr. Johnson. Again, if anyone has any questions, feel free to submit on the Slido app or also come up and talk with us. A question that we commonly get for COVID-19 is timing of when to get the vaccine. When is too early? When is too late? Do you have any comments or advice for practitioners on that?
Well, one issue that affects timing is whether you've recently had COVID-19. And so just mention that if you had COVID-19, then the recommendation is generally to wait at least 3 months, 3 months after before you get another dose. In terms of the timing, it has not been exactly seasonal. As predictable as either RSV or influenza. So I've tended, to kind of follow the epidemiology, because we still are tracking cases and so on. And I think I'm an early vaccinator. I don't wait till the fall or winter.
Yeah, when you have them in front of you, get them vaccinated.
Yeah.
Another question on clinical standards.
The other thing I'd say about timing is that we have to wait too for new formulations. So for example, in August, we knew the new vaccine was coming out in September. So that's the other vaccine thing, is potentially to wait for the new formulation if it's, a month or less.
Great. Another clinical scenario folks wanted your take on. So, if a new patient comes into you is Hep A and Hep B antibody negative. So, would you recommend the Twinrex or Heplisav, or and with a separate Hep A? And this is in the context of someone living with HIV.
Yeah, I mean, we still list the Twinrix vaccine as an option in the guidelines. I personally prefer an approach of giving the vaccine separately. Now that we have Hepliseb B, which is just a two-shot series, so I give both. I give the individual vaccines at time 0, and then just give the Hepliseb at 1 month, and then the Hep A vaccine at 6 months. In younger individuals, a single dose of Hep A vaccine is pretty protective. Mm-hmm. So I'm not too worried about kind of that period of time. So I've been giving them separately, but it's not wrong to give the Twinrix. But I just think the Hepliseb B is such a better vaccine that I go that way.
Yeah, and to that, there's another question talking about is there recommendations on how to manage patients who received an incomplete hepatitis B series from both regimens. And so, for example, if they're starting to see that they got 1 or 2 of the Energics and then an Heplisav, like how do you reconcile if someone has started one regimen or one of the vaccine series and then has switched to the other vaccine series itself?
Well, I think there's room for clinical judgment here. And the nice thing about both hepatitis A and hepatitis B is we have tests to measure immunity. So, if somebody got 2 doses of the alum-based hepatitis B vaccine, and then they came in and you gave them 1 dose of Hepliseb B, and their titer in a month is greater than 100, then I don't think you're always obligated to do the full series in that setting.
Okay. And talking about a vaccine series that didn't make it to your talk, but talking about meningitis and specifically the Men-B vaccine or the Men-ACWY vaccination in folks living with HIV, recommendations or thoughts specifically on that?
Yeah, concerning the quadrivalent vaccine, it is a recommendation for all people living with HIV to get that vaccine and to get booster doses and so on. It was based on studies that showed like a 5 to 11-fold higher incidence of meningococcal disease among people living with HIV, and even though it was associated with certain types of exposures that might place people at risk, the CDC and ACIP decided to make it a universal recommendation. I think that vaccine is a vaccine that some of my patients are kind of, come on, I'm 80 years old, I don't really need that. And so we do get some declining, but unless something's changed very recently, it still is a universal recommendation, including those boosters every 5 years. In terms of the Group B vaccine, it's really only recommended for the subset of people that meet criteria for Group B vaccine. So HIV itself is not an indication, but post-splenectomy, for example, and so on. You mentioned about the observation of some protection against gonorrhea with the Group B vaccine, and if some of those studies, when they're resulted, show some benefit, then our guidelines might change. The other thing to mention here is there's 2 FDA-approved pentavalent vaccines that have all 5 serotypes in it. And right now it's indicated for really adolescents and young adults if they meet criteria for both vaccines. But I could kind of see a scenario in the future where if we show some benefit of the Group B vaccine against gonorrhea, I could see maybe a pentavalent vaccine becoming an approach for people with HIV. But for right now, the Group B vaccine is just the standard indications.
Sure. I'm going to combine 2 questions related to serologies around MMR. Some things that some clinics are screening, measles IgG alone, while others are screening for IgG against measles, mumps, and rubella. Given the current concern with measles, is it necessary to screen for all 3 when you're trying to assess someone's immunity?
Yeah, that's a good question. And a question that also comes up is, why don't we do screening for measles, mumps, and rubella and varicella as part of our standard laboratory work when when people are newly diagnosed with HIV. In part, we assume that many individuals living with HIV diagnosed in the U.S., you know, probably have received their standard childhood vaccines, and we kind of screen that as part of the history. So we've not, adopted kind of a serology, kind of for everyone newly diagnosed with HIV. In terms of, screening for measles, mumps, and rubella, rubella is not really an issue in the United States, but mumps is actually, a significantly common illness, and so I've been screening for all three and providing vaccination if any of the titers are negative.
And how do you approach folks that don't have responsive titers after vaccination itself, specifically to mumps? I feel like that has been a scenario that folks still don't establish a titer, but you have vaccinated them.
Yeah, I mean, you can, after 2 doses.
Oh, yeah.
Yeah. Yeah, I don't know how to manage it after 2 doses. If you've given 1 dose and you haven't seroconverted, you can give another dose. But yeah.
Dr. Benson, please. Sorry.
Concentration on measles. There have been several outbreaks now of pertussis, also in the vaccine hesitancy group. And I wondered if you'd seen adult cases of pertussis in your HIV population, or if anyone else has, and what you do for people with HIV around vaccination against, our Tdap vaccines.
Yeah. Well, maybe we'll start with kind of a show of hands. Who's managed an adult pertussis case? Yeah, I mean, cases are reported, but I've actually not seen it in our population with HIV. How about in Chicago?
I have not managed adult pertussis, thankfully, but who knows what next year will hold.
Yeah. Yeah. I mean, unless something changes, I probably wouldn't deviate from a kind of current practice of, but I have, the CDC guidelines, for a while would say, give Tdap and wait 10 years and then give either TD or Tdap. And I've always consistently given Tdap for that reason, the fact that there are pertussis cases in the US.
Another great question talking about the term immunocompromised, and really mentioning that the whole umbrella term immunocompromised can be somewhat problematic, that we tend to agree that it is anyone with the CD4 count under 200, but a lot of our patients living with HIV think just having HIV by itself is somewhat immunocompromised, even if their CD4 counts are quite elevated. And so trying to think about how best to message to our patients living with HIV that just because of their diagnosis itself is not meet their criteria for immunocompromised, or do you feel like everyone living with HIV should be considered in some degree, immunocompromised or some sort of immunomodulation?
Well, when we kind of, as you mentioned, I was involved with the COVID-19 treatment guidelines. I mean, we defined immunosuppression with HIV as a CD4 count less than 200. Mm-hmm. But, a CD4 count less than 200, that was somewhat of an arbitrary decision made, 30 or 40 years ago. And somebody with a CD4 count of 350 does not have a normal immune system. So again, I tend to kind of maybe individualize the approach and so on. I mean, somebody who's 25 with a CD4 count of 800 is probably not immunocompromised, but somebody with a CD4 count of 350, 400 probably is immunocompromised, and in the studies may have an impaired response to vaccine.
Sure.
Yeah.
A question about folks living with HIV who are varicella non-immune. Can you skip the varicella vaccine and go straight to a shingles vaccination or Shingrix for those individuals?
Well, the advice is no, and I'm smiling because it's kind of, I've gotten this question several times, and it took me a while before I figured out the answer. But if people are seronegative for varicella and their CD4 count is greater than 200, they should get the 2-dose varicella vaccine. That's what's recommended. And then the question that comes up is, then do you subsequently give the recombinant zoster vaccine, and how soon can you? And I finally found advice in one of the recommendations that you can give it after 8 weeks. So you can give the 2-dose varicella series and then wait 8 weeks and then start the 2-dose zoster series. So
a question about the COVID vaccine. I think, we're, 5 years into 4 years from, the vaccine itself, or well, actually almost 5 right now. What is the approach we think for patients who have previously received COVID vaccines? Are we accepting the fact that we will have an annual COVID vaccine like we have an annual flu vaccine? Is that what is going to be the conventional wisdom from here on out?
Well, I mean, I think this is in evolution. I think it's something that in kind of a related question is, will COVID-19 stay kind of a universal vaccine? Just to digress for a moment, if you think about the 3 respiratory virus vaccines we have, influenza, we've taken a universal vaccination approach for decades. Everyone 6 months and older gets an annual vaccine. And now we have RSV vaccines, but from the very beginning, we've taken a targeted approach. Age 75 and older, everyone gets it. Younger individuals, 50 to 74, that have a risk, and we're taking a targeted approach. And so the question is, with COVID, is do we take a universal approach or do we take a targeted approach? And I think for the near term, I support universal vaccination for people with HIV.
Sure.
But if you look at kind of the deaths of COVID-19 in the United States, it's impressively low, and this continues to evolve. So I think it's something that probably each year needs to be reassessed. And there are certain health departments in other countries that are already taking a more focused approach to COVID-19 vaccine. But I think for reasons you mentioned, that people with HIV may have varying levels of immunosuppression. I feel like it's important to kind of stay on schedule.
Sure.
Until we know more.
Syra, please go ahead.
Know that the CDC gave recommendation that the COVID and the flu can be given together. Is there any contraindication in regards to the COVID vaccine being given in conjunction with any other vaccine?
No, it's been a study with a lot of vaccines, and I'm not aware of a vaccine that you can't give it with COVID. So we routinely kind of give it with, like if somebody's newly diagnosed with HIV, you can give it with pneumococcal vaccine or Tdap and so on.
Okay, thank you.
We got maybe time for one last question. So here asking, how long after shingles disease would you recommend Shingrix or the shingles vaccine?
Well, you probably do get some immunity from shingles, but I think the recommendation is after clinical resolution of the illness. You can do it anytime after that, but the lesions have to resolve and so on.
Great.
Sorry, I keep turning my head and yeah. I'm sorry if you're missing some of this important information.
And I guess, yeah, with the last minute, we have a question. Does vaccination with the chickenpox vaccine for a non-immune individual not now lead to the potential for shingles, whereas Shingrix alone may not add to that potential risk?
Well, I think there have been cases of shingles in that setting. Yeah, it doesn't really alter our algorithm.
Great. Well, thank you, Dr. Johnson. Thank you so much for your help and enlightening session. And we'll move on to the next talk speaker.